on racism as a threat in our healthcare system. We have 3 speakers today. They're all fabulous. Our first speaker will be Lelieth Thompson. She has a doctorate in psychology. Our second speaker will be Sara Wright, who's a social work student at Metro State. And our third speaker will be Dr. Madeline Jacobs, who is the chair of the Medical Professionals for Universal Healthcare in Colorado. I just want to welcome everybody. Please know that I know a lot of people want to talk about justice, equity, diversity, and inclusion issues. And our task force will be meeting on December 5th from 5:30 to 6:30 online. You can register on the State League website. So we'll start today with Dr. Lelieth Thompson. She completed her education at South Carolina State University and went on to Adler University in Chicago to complete her master's in counseling psychology. Then she got a doctorate in clinical psychology. She's provided mental health services in a variety of roles over the last 12 years, including inpatient psychiatric and residential care, county corrections, behavioral health consultation supporting medical providers, and community mental health and community-based chronic care teams. Lee currently serves her community in a private practice, treating adults with a variety of mental health concerns, as well as co-owning a grassroots organization promoting BIPOC mental health in the Colorado Springs area. And BIPOC, for people who don't know it, is Black, Indigenous people of color. So each speaker tonight will speak for about 10 to 15 minutes, maybe a little bit more. And we'll have plenty of time for questions at the end. Please put your questions in the chat so that we can get to them expeditiously. Thank you very much for coming. And Lee, take it away.
Hi, everyone. Thank you so much, Kathy, for the invitation and having us here today. So I'm going to start off this panel really just kind of sharing some stories that really highlight how much racism is systemically impacting the lives of so many people, especially in negative ways. Some of those stories are going to focus on physical health in one area and some more in some mental health areas. So for example, when it comes to Black maternal health in this country, Black women are at the highest risk for death and significant difficulty and complications during pregnancy and birth. Sadly, that is very much so deeply in racist biasm, right? There's a lot, the man who was the founder of modern gynecology did a lot of testing on enslaved Black women, saying that they could extend pain so much more, and how much that really does kind of negate what's happening when pregnant women are in labor. I need pain management. Oh, the pain's not that bad, or I'm having complications and being ignored for that. It doesn't even matter what your economic status is. There's been a lot of things that happened publicly. I believe it was maybe 5 or so years ago now that Serena Williams, who, is a very acclaimed Olympian and athlete in the tennis world, she had her first child and she was ignored for blood clots and almost died because of this. So this is someone who has access to the best kind of healthcare available to her, yet racism still showed up in that space and was denying her really great access to care that put her life at risk. There's also challenges with how women now, especially as things are changing in our states, especially with certain laws that are getting, abolished because of abortion rights and healthcare access. There are women like Josely Barranca, who in Texas in 2021, because of that ban, was having a miscarriage and wasn't able to give birth or able to have a D&C because of the laws. And unfortunately, she passed away due to that, right? So another Black woman having need to get access to healthcare and being dismissed because of economic status as well as the laws preventing her having access to that care. Um, Even things as like Henrietta Lacks, if that's a name that everyone's unfamiliar with. She is a Black woman who had a very aggressive case of cervical cancer. And with that, without her consent, they used a lot of her genes and cells to now utilize a lot of ways to manage other treatment like cancer and other genetic health issues. Yet she didn't even know about that being utilized. So again, bodies just kind of being used to get more research in healthcare but not actually being applied to taking care of those individuals. Um, in a mental health space too, and this I have a lot more, space here, and this is where I practice. A lot of my clients are BIPOC, and the reason that they are challenged with getting access to care is the fear of not finding providers that look like them. I know that I'm one of few Black psychologists that's licensed even in the country. I think there's about 5,500 licensed Black psychologists nationwide, and that's just at this doctoral level. And only maybe some tens of thousands at the master's level. In comparison to the amount of people providers, that's not that much for the demographic that needs the support. And so often Black and Brown people avoid going into treatment because they feel like they're going to be judged or be discriminated against, and those things do happen. As recently as a month ago, I was doing another panel discussion like this with Black women about mental health, and everyone in the room raised their hand saying they had been to therapy, but they also agreed that they were less open to returning because of instances with their white providers. One woman shared a story that she had suffered loss of her brother due to gun violence. And for whatever reason, the therapist decided to assume, oh, was this gang related? When that wasn't the case, that was not something that was mentioned or brought up even in the session, but that alone showed so much judgment that that client didn't ever feel safe to be in that room. Um, there are also techniques within the therapy space, like cognitive behavioral therapy, that can unfortunately minimize the experience of Black and Brown people. If they're coming to tell us that we're having emotional distress about maybe working in white spaces and I'm emotionally distressed and my job is treating me as such, a white therapist might be saying, oh, that might not be anything to do with you being your race, that's just probably your performance, or maybe it's like how you're presenting yourself to others, where it may be some of that, but there are often a lot of times where there are discriminations in these places that people come to therapy to process and then are dismissed for that or told that it's not quite that because that person is unable to maybe see past their own privilege. Even though we are required to do a lot of competency training and clinical training to be really aware about different cultural differences, it's very limited, unfortunately. Unless you are taking a lot of your own initiative to continue some of that training, you can be very limited by what is taught in school, which sometimes also is surrounded with, white supremacist values and like the access to healthcare, more so than it is with true nuances of working with people of culture versus just the stereotypes of those things. I can recall several times and even like textbooks and training where here's what we're going to talk about with Black population or the Asian population or the Hispanic population. It's often relatively brief and pretty much the same, but then people go and do treatment and feel like they're prepared and don't really pay attention to the nuances of how much those things are way more than the stereotypes, and that they also have a lot of similar experiences that everybody else does, but then they get pigeonholed into one way based on just their physical presentation. Um, I'm happy that mental health is becoming less and less stigmatized for people in general. However, it's not becoming safer for people of color. They are still feeling this is something that they can't access. This is still healthcare in a way that is not for them. There's a lot of distrust in the healthcare system, and rightfully so, whether it's because we've been experimented on, whether it's the things like I mentioned, like maternal health services, or even things like the Tuskegee Project, where 400 Black men were tested or told that they were giving vaccinations, and they ended up having syphilis, and people were dying from that. Right? Our bodies have been tested and utilized to advance healthcare and medical systems, yet we are still the least people getting the best care, having access to it. And so we really need to pay attention to how much systemic issues with racism impact all these different spaces. And it's not just physical health care, but it's whole body health care. And if we're not taking care of our mental health, your physical health is often going to decline and vice versa. And so I think it's just very important to recognize that these things need to be paid attention to, and that it's important for people to be aware of their implicit biases toward different people, because it has a negative impact on the fact of them accessing care and their overall health outcomes. Pass it off to Sara now.
Thank you, Lee. That was awesome. We'll have questions at the end, so please put your questions in the chat. There's a lot to think about with what Lee just said. It's hard to get your head around how all of those issues that I certainly haven't thought about. Sara, you are going to speak next. Sara Wright is the Director of Communications at Colorado Foundation for Universal Healthcare. She wrote her first story on healthcare as an investigator on Boulder's nursing homes at age 17. In addition to writing and editing for news sites in Colorado and in South Carolina, she's worked in marketing for a healthcare group purchasing organization, in health insurance billing for a psychiatrist. She's a certified massage therapist. She's also attending Metro State, getting a master's in social work. She's committed to social justice, co-writes songs and plays bass in the band Radiant Deep Bass. Sorry.
Yes, I know.
Bass in the band Radiant Deep, and loves to dance. Her experiences working in Colorado for Universal Healthcare, owning her own business, and as a mother and type 1 diabetic, all give her firsthand understanding of the need for quality, affordable healthcare for all. So Sara.
Thank you. Thank you so much, Kathy. And I just want to say that we are so thankful and blessed to have Lee is also with Colorado for Universal Healthcare. She's our board vice chair. So, and I also really appreciate the image I just had of me playing a bass fish. That was fun. We really need all the levity we can get right now. I really want to thank all of you for being here. The fact that you're here means you care about improving racial justice in healthcare and in general. And we at Colorado for Universal Healthcare thank the Colorado League of Women Voters for hosting this event. So racism is a public health threat, and you may have heard that, but I'm just going to quote the CDC. In April of 2021, the CDC declared that racism is a serious public health threat that directly affects the well-being of millions of Americans, and as a result, affects the health of our entire nation. CDC has long recognized that racism is the root cause of many health disparities. And racism is an ongoing stressor that impacts millions of Americans of color on a daily basis. And this can be everything from traumatic interpersonal events, violence, or being screamed at, to microaggressions, and is also often experienced through systems. Racism has played a role in our systems throughout history, including healthcare, impacting people of color in education, access to quality jobs, housing policies that have privileged white people and disadvantaged people of color, excessive police force and incarceration used against people of color. And many of these systems remain in place, functioning in many ways as they were intended. In addition, we must acknowledge that bogus science was used to justify slavery and genocide, and ongoing horrific treatment of Black, Indigenous people of color, and remains, unfortunately, a part of our nation's psyche. In 2016, Hoffman et al., a group of researchers, showed that over half of their sample of American medical students and residents held false viewpoints about biological differences between white and Black patients, and assumed that Black patients had a higher pain tolerance and thicker skin. Now that's just flat out not true, but these racist views from bogus science that was used to justify slavery have real life consequences. A meta-analysis of that covered 20 years of research found that Black patients are 22% less likely than white patients to receive any pain medication at all. In reality, and I'm sure many of you know this, people of all so-called races share 99.9% of our genes. Race is a societal construct harnessed to create a system of oppression that benefited white people. And I have to say, so why isn't it fair to say we're colorblind since race isn't real? And it's because Americans of color experience real life hazards every day of living in this country while brown or Black. So this is really cool. And this came to my attention at our last event. The Institute for Healing and Justice in Medicine, which was founded by former medical and graduate students while they were still in their programs at University of California, San Francisco School of Medicine and UC Berkeley School of Public Health. They devoted countless hours to researching and writing their report toward the abolition of biological race in medicine, transforming clinical education, research, and practice. It debunks false narratives in the health sciences that link biology and race. A main tenet of the 67-page report: racism, not race, causes health disparities. So there's a few themes I'm just going to talk about briefly. One is that racism, and Lee talked about this, I'm so glad you shared those stories, Lee. It's better than all this book learning, honestly. But racism is experienced in healthcare settings, and we might not know that as a white person. I wish I had 25 close friends of color, but I probably have fewer than 10. And yet 4 or 5 of those have had really, really terrible experiences of being sent home or not listened to. We have a board member whose aunt was sent home twice with COVID because they didn't think she was sick enough from the hospital, and she ended up dying. I talked to another woman recently who lost a child in Colorado from not being heard about her symptoms. And KFF, formerly known as the Kaiser Family Foundation, has found that immigrants face discrimination in healthcare, Black and brown people do, LGBTQ community does, the disability community does, and women do. I mean, women and BIPOC people are not included in general in research about how to take care of people. Second, racism affects physical and mental health, which again, Lee talked about very eloquently. Mary Jude Senna in 2023 created the framework of complex racial trauma, demonstrating that those with racial trauma experience multiple traumas beginning in childhood, have increased symptoms of PTSD, and that exposure to racial trauma has large and lasting negative impacts on one's health, including biological impacts from central nervous system stress, as well as career, mental health, use of substances, socioeconomic status, and the quality of relationships. And I just want to take a deep breath because it's hard to listen to, and there's a lot more. And I just want to say that this does not define people. No matter how much trauma there is, doesn't say who people are. Racial discrimination also puts Black Americans at risk for alcohol use and related problems due to experiencing symptoms of depression. Evidence shows that when people of color have frequent discriminatory interactions, it can increase their feelings of inferiority and drive them to drink. And then we've heard, I think pretty commonly, that racial and ethnic minority populations experience higher rates of poor health and disease in conditions like diabetes, hypertension, obesity, asthma, and heart disease, and have a lower life expectancy. But one thing that's really important to point out is that systemic racism is the cause of many of these social determinants of health that negatively impact BIPOC folks, including Native Americans, Latinx communities, and our nation's immigrants. Being a racial or ethnic minority increases your exposure to racism and of economics, and you're more at risk of poverty, and living in a socioeconomic disadvantaged neighborhood makes it more difficult for people to stay healthy, and is itself a risk factor to develop many health issues and diseases. So Black youth are more likely than white youth to have persistent exposure to neighborhood disadvantage between ages 0 to 17, which is associated with significantly greater probability of being obese at least once in early adulthood. And I just want to throw this out because we hear in the universal healthcare thing a lot, like, I don't want to pay for someone else's healthcare because it's their lifestyle. They just, it's like, oh, really? Sorry. Okay. And then you've probably heard the term intersectionality. That's when you have more than one type of oppression. So, women are oppressed, and people of color are oppressed, and LGBTQ people are oppressed, and people with disabilities are oppressed. So if you're a Black, female, queer person in a wheelchair, you have like 4 layers of this crap on you. So this is some cool science. There's some good science too, that's helping people, at least helping our understanding. So the intersection between stress and genes increases the risk for Black women for a variety of conditions. Cortisol, the stress hormone, actually switches genes on and off, meaning our genes are at the mercy of our behavior, as well as our behavior being at the mercy of our genes. This is from Matt Ridley, the author of Genome, the autobiography of a species, in 23 chapters. When a stress gene is turned on in a pregnant mother, the baby will be born with it turned on as well. So maternal stress and intergenerational trauma are quite literally and physically passed down and can directly impact health. This stress gene microlens puts into context, for example, why young Black women are at higher risk of so many different health issues, including breast cancer. And I wrote a paper on young Black women, lest you think that I'm picking on them for a reason. I have a daughter named Harmony, and I don't know if you guys remember that New York Times article about Simone Landrum, who lost her daughter, Harmony. Sorry, I kept thinking about her, Harmony. Chronic stress is a leading cause of various health problems. And young Black women face daily stress that includes exposure to gendered racism. So that's true for Latino women as well. And impacts of racial discrimination even change the white matter microstructure in the brain, particularly in women who've been exposed to other kinds of trauma, which can lead to increased risk for neurological disorders and mental health problems. In other words, despite the fact that people of color are the least likely to have access and feel safe seeking mental health care for all of this, they really could probably use some support. And when we talk about intergenerational trauma, it's important to think about Native Americans and the American Indian schools, or immigrants now who are leaving terrible violence to come here and face what they're facing here. So American Indians face pervasive trauma exposure, collective histories of communal suffering, and elevated risk for depression and post-traumatic stress. And like we've been talking about, for Black Americans, in addition to socioeconomic barriers, access to culturally responsive treatment for Native Americans is also limited and may compromise treatment engagement. So that's a lot. We're gonna talk about what to do about it, which of course, given where we are from, we believe that universal healthcare could make a big dent in it. It won't completely transform the minds of the providers. There's other issues to address, but do consider that when Medicare was passed in 1965, all US hospitals finally integrated. Okay, there was huge resistance to integrating hospitals. And before Medicare passed, they would let people die outside before bringing them in the hospital. Then suddenly Medicare passed, and you had to be integrated to receive federal funding, and every hospital in America integrated overnight. So there's power in single payer, right? And the other thing to consider is that in the VA and in Medicare, many of these health disparities are much lower and like way better for all these different populations. And the VA and Medicare are micro universal healthcare systems. So while access won't cover everything, it would make a huge difference. Okay. So and we want you to look at our website. I'll put it in the chat and get active and all of that. But Maddie's going to talk next. I think everyone needs a massage.
Our next speaker will be Dr. Maddie Jacobs. Dr. Jacobs was a rural family physician for 28 years, and she left her practice frustrated that our healthcare system wouldn't allow her to care for her patients. In her last year of practice, 3 asthmatics ended up on ventilators because they couldn't afford their medications. 3 other patients died of colon cancer because they couldn't afford their colonoscopies. Maddie felt that her life was a continuous battle trying to get basic care for treatable illnesses and decided to spend her time instead working for universal health care. Maddie has a quote in her biography that says, "In all the countries around the world that have made the moral decision to care for all their people, they pay half of what Americans pay, cover everyone, and enjoy better health outcomes." So Dr. Jacobs, thank you very much.
Thank you, Kathy, and thank you, Lee and Sarah. I'm the person who's trying to pull this together on what a direction to go in with this overwhelming systemic persecution that we have in this country. Just a quick relating of my experience on discovering my white privilege and just how pervasive it is. First of all, I was taught in medical school about Black people having thick skin and lower pain tolerances. And we had, quote, sensitive or community training so we could understand other cultures. And we were told that, on the other hand, Latino people have really low pain tolerances. But so if you ask, I mean, it's a cultural thing. It's not what they're actually feeling. So if you ask someone on scale of 1 to 10 what their pain is, they'll say 15. So we needed to dismiss that as well. And, you know, it's just so pervasive and horrible. And really, I'm on my journey to see my white privilege. And I happen to have some relatives who are Indigenous people. And as they were becoming teenagers, I saw what they had to put up with, which I was completely unconscious of as a white person. So that was very eye-opening. So how would single payer universal health care ameliorate the systemic racism in American healthcare? It's not a panacea, which is why I use the word ameliorate. And it is why it is incumbent to intersect with all social justice efforts to alleviate social inequity in this country. Perhaps the clearest way to see this is to crystallize the purpose of a healthcare system. It would seem obvious that the purpose of a healthcare system would be to maximize the health of the community. Unfortunately, that is not the purpose of the American healthcare system. Its purpose is to maximize profit by collecting money while denying care through the erection of obstacles, including ever-increasing premiums, co-pays, co-insurance, fragmentation of care, limitations of provider networks, and other arbitrary costs to the patient. The profiteers rationalize this by comparing healthcare to a free market system. It is not. One does not plan to have a heart attack, then check out what the best deal is to have one. It's not like flat screen TV. Because of this, we need a paradigm shift in US healthcare, a system with the purpose of maximizing health. It is based on the obvious fact that we all live in human bodies that will get sick, injured, and age 100% of the time. It is not only based on a basic moral principle to care for each other, but also the recognition that if we keep people as healthy as possible, we save money. This has been shown around the world. The US spends twice as much per capita, yet has the worst health outcomes of all industrialized countries around the world, which all, save the United States, have universal healthcare systems. The US has shorter lifespans, increasing maternal and infant mortality across the board, with the extra emphasis on people of color, and increased death from treatable disease from these other countries, and in fact, of countries that are much poorer. The difference? We prioritize the profits of the few, they prioritize the health of their people. Factors that would be improved would be, if we did have a single payer system for BIPOC people, would be affordable care. Still, we need to make sure the system will address the other inequities of the system. Helping BIPOC people access affordable training as healthcare providers to address the fear patients have of the healthcare system that has mistreated them since the founding of the country. Recognizing and addressing healthcare deserts in urban and rural areas. Supporting public health is a necessary way to maximize the health of the community and dovetailing with individual health. And supporting continuity of care by emphasizing and supporting primary care. It has been shown around the world that this can be done. We can build a system in the US that recognizes that all humans need healthcare and that our society thrives when it is provided. Thank you.
Thank you so much, Dr. Maddie. We can take questions now. If anybody has any questions, could you put them in the chat? If you don't, I'll lead off. I have some questions, and maybe we can get into a discussion type venue here. My first question has to do with Thalia, do you have any questions?
Why don't you get started? Go right ahead.
My first question has to do with, or I think it's more of a statement, that as a white person, I recently became aware of the disparities in healthcare, such as the maternal mortality disparities are pretty evident. And I was shocked to learn that that had nothing to do with income levels, because I think there's a lot of people that think, well, it's just a poverty problem. And that poverty causes, a lot of social things like poor eating and access to healthcare and things like that. But one of the things that I've recently been thinking about is the fact that just living day to day with racism causes biological changes. And that's just so overwhelmingly astounding to me that I think we need to all be aware of that. And I think we need to focus on that, because it's too easy to blame it all on, well, they just have a disproportionate amount of poor people. That there's problems at the very basis of the healthcare system. And then Lee's discussion about having providers that look like you. For myself personally, just the fact that there are now women doctors has been such a change in my life. It's made me so much more comfortable in the healthcare system. And when you realize that most Black, Indigenous people of color don't have that that availability. I think that that's like another huge problem. And then as far as medical providers being told that there are biological differences with Black, Indigenous, people of color, I was like, has there been at least any progress in the medical schools, in the training of medical professionals? I know, Lee, you said you didn't have much training in it, but I'm hoping that maybe there's been a little bit of progress or that people are concentrating on that. So could you talk a little bit about is there any kind of improvement? Is there any movement?
I think I want to say yes and no to that. I only graduated from my doctoral program 10 years ago. So this is not so long ago that these conversations were happening. I see it a lot amongst even therapy groups that I'm part of nationally, like on like social media, where there's always conversation about how are we serving this BIPOC community? How are we supporting people of color? How are we even trained up enough? And there have been people who are able to kind of give more space to that, but there are a lot of people who I think shy away from it or assume, oh, I know this. I'm not going to have my biases. I'm going to be anti-racist, and how much that's not just a goalpost stop, like it is a entire lifelong journey. We're all been deeply conditioned to these biases. And so I think that in the training spaces, it's still happening because the textbooks only change but so much, or sometimes they use the same things that kind of just get regurgitated for historical context. But again, I think it's dependent on the institution that you attend, the professors that you interact with, the trainings facilities that you go to. It's actually kind of funny. In my cohort of 75 people in my doctoral program, there was only 7 of us that were Black, and 2 of them were men. And one of them was a man, actually. No, the other guy was the master's program. But out of that, we all thought it was so interesting that even though we didn't maybe have a lot of practicum training directly with Black and brown populations, we were very intentional that all of our dissertations were around Black health and research, because we're like, if we have this opportunity to contribute this in these ways, this is how we do that, because it's not necessarily forced upon in our school. Now, comes to the other school, and so they do a pretty good job of really paying attention to a lot of systemic issues as a whole. Adlerian psychology does have a lot of like community tenets and the way that they take care of one another. And so we actually had a really great research facility that did some stuff around incarceration more in particular. That was kind of a requirement that all students had to attend. So that did kind of help show, you know, how there are some definitely these barriers to success or care, even in the judicial system, by like, oh, I have to go do these things, and how quickly, if you don't get to certain places because you don't even have access or resource for that, you still get penalized for it. And so I think it really is program dependent, interest dependent, wanting to actually be more involved in race-based issues and treatment. I know for me, when I talk about like trauma work with clients, I always run through a list because I think people are very limited in what they conceptualize as trauma, especially being here in this military town in Colorado Springs. So I often even say I work with people around race-based trauma. And some people are like, oh, because like you mentioned, walking in the world as a person of culture, despite whatever intersectionalities you have, we can't really cover up our skin. Like we can maybe hide that we have other quirks, or we could hide maybe our queerness, or we could hide certain religious aspects of ourselves, but we cannot hide our Black and brownness. Some people may have passing, but why were people passing? For access to more equitability, versus it was like denouncing their Blackness. And so there is a huge just threat of walking in the world looking the way that I do, even despite having privileges that I have access to. There are going to be plenty of people who see me and make judgments or deny me certain access to things or minimize what my care and my healthcare accesses look like. I've been pretty lucky. I would say, like, because I was a military dependent for so long, that I've been part of a universal healthcare system. And so I got to have access in that way. But if I didn't have that much access for other reasons, I can't imagine that maybe I would have the health I have today, because I might not have those resources because the military was able to provide that for me and my family.
Mm-hmm. Talia, is there any questions?
I've got one. No, there's nothing in the chat yet, but I've got one. Does anybody in this group know how the Supreme Court's striking down of affirmative action in relation to admissions to higher education facilities, has that changed the percentages of brown and black folk getting admitted, not just to med school, but to, you know, PhD programs and social work programs? Does anybody know if that's been negatively affected admissions percentages for diversity reasons?
I can't say like more like specific things, but I'm definitely aware that there have been changes. I know that there's even been lawsuits from, I think, Asian students in particular recently about affirmative action and how that's impacting admission. So I can't imagine that it's not already happening to a lot of other people in institutions just no longer investing in that, and so that they're giving more access to BIPOC students.
Here's something Deb added to the chat. When one really understands the social determinants of health, it becomes obvious that every single social, cultural, economic, and environmental issue we don't address ultimately ends up in the healthcare system. Race, ethnicity, gender identity, etc., are certainly additional risk factors, and issues like provider bias should be addressed. However, if we are going to control the rising demand for healthcare services based on the combination of social determinants in the context of an economically viable and fully accessible healthcare system, it seems like we need to connect broader strategies that address the sources of the need for healthcare. How would you prioritize the larger issues in terms of the impact on vulnerable populations? And Deb, you can unmute yourself if you want to add to that at all, or you know, go ahead and have a conversation about your concerns. Then any of our
I think Maddie's got her hand
presenters,
up.
that's the word I want. Yeah, go ahead.
Yeah, I actually raised my hand in response to the previous question about affirmative action.
Oh, good. I didn't see that. Sorry, man.
And the New York Times has actually had several articles about the impact that that Supreme Court ruling has had on the admission of minority students, and it already has had an impact. But I also want to bring in the other aspect, which is the cost of tuition for professional training. You know, at this point, I was just at my 40th medical school reunion, and the typical medical student, and that's all the medical students, are coming out of that with basically a mortgage to pay back. It is, you know, we're talking, you know, hundreds of thousands of dollars. And that on top of the systemic racism that has kept these populations downtrodden by the system, you know, just makes it even more difficult for people to be able to obtain that type of training. I highly recommend to people, if you haven't already read it, The Sum of Us, the book about systemic racism, because it is an incredible explanation of how the system of racism has been going on since creation of this country and the repercussions that it has to this day. And of course, now I don't remember the question you asked, Talia.
Deb, you want to elaborate?
I know it was a really long, kind of involved question, but I've taught health ethics and health justice for 30 years, and have finally come to the conclusion, unfortunately, that issues like provider bias are things we absolutely need to keep working on. We need to keep addressing. But I don't think they're going to solve a lot of the basic issues of access to healthcare. And while the single payer system sounds good on paper, and I completely support that concept, Medicare is the best insurance you can get in this country right now, and is probably the most efficiently run provider of health insurance in the country. So I mean, there's huge economic arguments for that. But the reality is the cost of healthcare is skyrocketing, not just because of insurance premiums and not just because of greedy pharmaceutical companies and hospitals and all of that, but truly because as a country, we are seeing dramatic increases in or undermining of the social determinants of health on so many different levels. And to make the healthcare system affordable, one has to not just change how the healthcare system itself is structured, which I think is even more important than the single payer system, so that its focus is different. But I also think there needs to be recognition that we need to stop the flow of people into the healthcare system, that we need to address a lot of those basic economic, social, cultural, environmental problems facing us that keep funneling people into the healthcare system, but that appropriate policy might actually address before people get into the healthcare system. I certainly teaching this, that's one of the first things I tell students coming into this particular course is everything we don't do well in society ends up in the healthcare system. I mean, give me one issue, just one single issue, that's a policy issue right now that doesn't somehow affect people's health and isn't responsible for undermining the health of the population. The fact that it undermines the health of these vulnerable populations to a greater extent, it is completely true. I mean, I completely acknowledge that, but it just seems like systemically we need strategies kind of above and beyond just fixing the healthcare system. A
Right.
perfect healthcare system still has to address the fact that the more people you put into it, the more issues you put in, the more issues you don't solve on the outside, the increasingly more expensive and inaccessible the healthcare system becomes.
Sarah and Maddie, I don't know which had of you raised your hand first, so whoever.
Maddie's hand was up first.
Okay, great.
I thank you for that, Deb. One of the things I was really trying to emphasize in my little talk was, just having a single payer financing system is not enough.
Yeah.
And the big problem with the current system, as far as I'm concerned, which I push a little bit against some of the things you said, is it's not the number of people in the healthcare system, it's the purpose of the healthcare system. And the purpose of our healthcare system is to make a lot of money. That's why they can get away with charging $40,000 for a single dose of chemotherapy drug, when the research to develop that drug was paid for by taxpayers.
Yeah,
It's
I completely agree with
and
you.
profiteering. And
Yeah,
then the
you're right.
other thing is, in other systems around the world, they're spending half of what they are and they're covering everyone. And that doesn't mean that they're seamless, perfect systems, but they're a lot better than we have now. And again, the reason for that is the understanding that if people are able to maximize their health, then the costs go down, as opposed to doing sick care, especially for people with insurance, because then we can do expensive procedures on them and do upcoding and all that kind of stuff. So I totally agree with you. This needs to be systemic, which is why I mentioned those things when I was talking about this. And they certainly are. The intersectional thing is key, which includes the social determinants of health. So that's, I think
Yeah,
that's all I need.
I don't disagree. I don't disagree with you at all. I would completely redesign the healthcare system. Nobody's ever asked me, but I know exactly how I would do it. And it would completely alter the incentives. But altering the incentives in the
Absolutely.
healthcare system would address certainly some issues around chronic health issues and stuff like that. But if you just take an example like gun violence, fixing the healthcare system doesn't stop the flow of the extraordinary cost of gun violence to the healthcare system. So I mean, there just are so many environmental,
Right.
climate change, the health impacts of climate change are extraordinary. And fixing the healthcare system isn't going to address any of those. And so I worry that no one's really having that other conversation.
Well, I would say that we are. That's why we're.
Oh, that's good. This is
the-
my first time to be here.
and the intersectional nature of
Yeah.
it.
Let's give Sarah a chance, and then Leslie will come after that. And then I do have more questions in the chat. So
Yeah.
go ahead, Sarah.
Okay, well, first of all, to partially respond to Deb, I completely see your point, and we often talk about how interconnected all these different social environmental justice issues are. My thought is that the economics, the oligarchy, all of the wealth with the 1% is really fundamental. We've heard a lot in the news after this election that 70% of Americans are living paycheck to paycheck. And so the impact of economics, is huge in not only in terms of everything we're talking about, not focusing on preventative care and keeping people well and making sure that they have good mental health and stuff, but also the idea of self-care. So, we talk about self-care, and it's something that I became kind of an expert in after having a mental health crisis as a young woman and sort of healing out of that. And I go to school at Metro State with a lot of young people who are working full-time and they're in school full-time. And there's a lot of training for the social work program about self-care, but they can't afford to not do both of those things full-time. And it's devastating. And we've heard how hard it is for young people out there economically. And it's just outrageous. So it's like the things that we talk about a lot, those of us who live privileged lives, be time in nature, time to meditate, healthy food, we know that. If I was working 2 jobs, I mean, I literally think about those people working in the chicken farms, like how's your self-care there? Like, it's just unimaginable how we treat our fellow humans and our animals for that matter. So I would say something about the economics, but then to Bill's point in the chat, there's a reason why a lot of us have chosen healthcare, because it would take such a huge knock at the thing that's downing Americans the most economically. One of the things that's really hurting people, it's driving people to homelessness, medical debt is. And so we tend to like it because we feel like it addresses more than one, but your point is well taken. And there was one other question in the chat that was, is it okay if I just, Shanna Tracy
Sure.
asked about the
Yeah, and then we want to get to those who have their hands raised as well.
Okay. Well, it was just about with PTSD and, that people have good reason to fear the healthcare system, and they're afraid of being turned away, and that getting people who need care to seek it could be problematic. And I just want to say that, yeah, people are really distrusting of healthcare providers, and there's a lot of historical context for why. And Lee could probably say more, but I guess I'm shutting up so we can get more people with their hands.
Okay, Leslie, go right ahead.
So basically, there's a movie that you've all heard about, a documentary called Healing Us by Dr. Joe Jarvis, a family practitioner in Utah who for the 20 years has been advocating for single payer health care. And the name of that documentary brings up a theme that, is kind of embedded in some of the malaise in our country right now, which is a lack of faith in the government for one of a million reasons. An example is I was talking with my housekeeper today about how I got fined for going across the the line, the double line between the express lane and the regular lanes. And at first I thought, oh, this is another ripoff. And then she said, no, that's keeping people from getting in accidents. 60-mile-an-hour people, when you change lanes, you know, that happens. But then the next word out of her mouth is, but I hate the fines because I hate the government. So the idea of healing us is we all get sick. If we had that sense of security that at least that little piece of our lives, we have a place to go where we would know that there was somebody there who was looking over our personal health and all the financial risks and the misinformation. But in European countries, they laugh when they hear about having to pay for everything in this country. But I'm just talking about that it changes the psyche of the nation, you know, and the trust. And they've said, last thing I'll mention is I saw some statistics where used to be 70% of the population trusted their physicians. Now, so it's down to 40%. And the skepticism about healthcare, I mean, here we are with vaccinations. We are 1/3 of the world's, we have the highest rate of death from COVID of almost any country because people were so paranoid about getting vaccinations, among other things. Anyhow, the fact that it's part of our exceptionalism that is a disease in this country, and collective thinking, like in Canada, is just across the border. It's so much different. So anyway, this is a broader thing than just the racism part, but I think it's remarkable how these healthcare systems that cover everybody actually get people to change their value system. And they find out that sharing a room with an African American person is pretty enlightening. And that if you're out in the field as a soldier and you're dying and you don't ask them, where is this blood coming from that is saving my life? Was it from some African American guy? And I don't want it. Hell no, I'll take it. So anyway, that's a lot of going on, but I think
Thank you.
the idea is that a good healthcare system, universal, would bring our country together and would make some of the competitive anger be limited. It could help our psyche.
And in the chat, Virginia does say that if we save hundreds of billions of dollars on healthcare by simplifying it, then we'd have more money left over to address the social determinants of it. Kathy, and then, I think we missed one comment in the chat from Dr. Reitman, who says we need to emphasize more the benefits of affirmative action to fight harder against anti-affirmative rules like the Supreme Court ruling. It's another case of misinformation, is what he says. Did you want to comment on that, Dr. Reitman, before I call on Kathy? Excuse me.
Well, no, I just, thought that we we don't have enough. We need more. I think we need to confront the misinformation in this country on all different levels. That's all.
Absolutely. Okay, Kathy, go ahead.
Yeah, actually, my sister's sitting here. She has a question, and I would just say something afterwards.
Okay, sure.
I actually have two questions.
Hi, Sue.
I'm Sue Ebersberger. I'm Kathy's sister. And I guess I was thinking about when you said the purpose of the healthcare system is to make money, maximize the money that's made. And I was thinking about my mother and the fact that she had breast cancer at the end of her life. And the oncologist kept saying, oh, but I can keep her alive 4 more months. And, but the 4 more months would have been in and out of the hospital. It would have been, she was so heavily drugged that she couldn't have conversations with people. She couldn't read books, which she loved doing. She couldn't spend time with her granddaughter. And so I wonder if sometimes, and I'm a pastor, so I've encountered this piece a lot. Sometimes it feels like we're trying to keep people alive past the point at which life is really life, that life is fulfilling. And I've felt that pressure more from doctors than from families. So I wondered what you all think about that, in terms of maybe we need to be shifting some of our expectations differently so that the resources can be realigned to, I don't know how to say it even, to helping people live more full lives, meaningful, I don't know, more full lives than just to have time here on Earth. So I was curious as to what you all think of that. And then I have another question after that.
Okay,
Well,
Dr.
maybe-
Jacobs, why don't you take that one?
Thanks for that. I totally agree with you that, we're 100% of us are going to die. And so most of us want to have the best quality of life that we can. And I really agree with you on that. That is an across the board issue in our healthcare system, which actually has improved since the hospice movement began.
Right.
But quite frankly, the current goal of our healthcare system is not to keep people alive as long as possible, because with the obstacles put up for care, people are not getting timely care. And
Okay.
quite frankly, my sister died prematurely because we could not get her care. And,
okay.
and that happens all the time. People are dying from treatable disease because that incentive as far as I can see, is really no longer there.
Okay.
It's really about making money, not keeping people alive. So that's kind of how I see that at this point.
Okay. I have a question for you. If you're comfortable in answering this, I was curious when you said that you started to unroll your understanding of white privilege when you saw your relatives face the things they faced when they began adolescence. And I was curious as to what those things are, because I think sometimes we could see those things and not even see them. And so I just wanted to hear someone else's experiences of what they saw.
I'm really happy to share that with you. So this is a young man and young woman. And the thing that blew my mind with the young man, who I said is indigenous, was when he went into a store. We go into, as with white privilege, we go in, we don't have to show our receipt when we're leaving. In a lot of cases, people believe that we actually paid for it. He was followed around in stores and even was arrested for, quote, shoplifting, which he didn't. And it was all about the color of his skin. And likewise, when Trump won in 2016, my niece.
Okay, just a second, we can't talk about political people or parties, so.
Oh, I'm sorry. In any case, she was going home. She was getting her MSW, and when she came out after this, she was threatened and told to go back from where she came from, and
Okay.
threatened with sexual assault.
Okay. Okay. Thank you.
Thanks a lot. Sorry to interrupt. I think what I'd like people to take away with them from this discussion, is that when we talk about fixing the healthcare system. It's not the same healthcare system for everybody. And we could talk about the costs of different types of healthcare systems, universal healthcare system, and well, I believe access to care that would be provided by universal healthcare would be a very large benefit. We still have to fix the healthcare system that has implicit biases against people of color. We have to fix the fact that there aren't providers for people of color. And that has to do with no matter what healthcare system we end up with. So I think I'd like everybody to be able to take away from this conversation the differences in the type of healthcare people get, notwithstanding how in this country, even after the Affordable Care Act came into being and a lot more people got health care, that gives some benefits just by the fact that there's access. But the racism in the healthcare system, we need to address and don't lose sight of that when we start talking about different healthcare systems. And my question for Lee is there, what kind of encouragement or encouragement is there for people of color, especially now that there's not affirmative action? Especially in Colorado, if you know any in Colorado, is there any kind of movement to try to get more providers of color?
I'm not sure of any particular movements that are necessarily happening, because I think that you're right. And I see this definitely amongst discussions I've had with other peers in the field as well, is that I think Maddie mentioned this, like, it's expensive. It's insanely expensive to train to get to this level, or train in general. And then it's not just the cost of our tuition to go to a school, it's the additional tacked on costs that come within it. I always think it's so interesting that I used to have to pay $1,000 for a 0 credit class, and the class was my year-long practicum, which is, I go and do free training. So I had to pay to basically be a therapist for another organization for a year as part of my own training. And like, that tacks up, or the cost of licensure as part of to be a licensed psychologist, you have to participate in the match process, and that is a nationwide search. And you have to make, and are there even enough spots? I did the match twice when I was in school. The first year I did the match, I didn't match at a site, and so I stayed another year and then matched the next year. But within both of those cycles, there were 1,000 less training sites available compared to the students that were applying to them. And so it's not like you're not matching because of competency, it's just there's not enough space available for you. And even within that, I mean, I spent thousands of dollars catching flights to different cities and states across the country to interview with the hopes of landing a thing and then moving. I moved here from Chicago. Like, that was a lot. And I think I had a total of 12 different sites that I had to travel to and interview during my rotation. So it was very, very expensive. And then once we get done with school, you take your licensure exam, and the EPPP, which is what you said for a psychologist, is a very challenging exam. And statistically, Black students often do need to take it multiple times. There's interesting things about still, like, how education even is just kind of the differences in that, and how students aren't as prepared. And so some people either fail it and decide they'll never take it again because they could still work and have a good job as, like, they're considered doctors, can't practice as a psychologist, and they still work and maybe get compensated less because they're not fully licensed and they're supervised or work under their masters. But I think a big barrier is like the gatekeeping of the amount of money it costs to just train. And then once you are trained, I mean, every single year I have to do a certain amount of CEUs, and that also costs money. Or to keep up my licensure, my liability insurance alone is like $1,100 a year just to cover me for any kind of like malpractice things. And so it's very expensive to even train to get into this space. And so I think that is a really, really big barrier for sure.
Yeah, just really quick, the social work licensing exam, they just released data, and there's all this data that people of color weren't passing it at the same rates. And the first thought that people have is like, oh, they're not studying as hard, or oh, they're not as qualified. But there were all these examples of people taking the exam and pretending to, like, thinking like, okay, I'm going to pretend I'm a white person and I'm going to take this exam, and then they could take it. Like, there is racism in the licensing, and actually Colorado just did away with that being the required exam for social work, and it's actually it's a liberatory decision. So that's really good. And I was going to connect it to something else, and I did want to let Lee have the last word, but I just wanted to say that, somebody was talking about, I think it was Lee, about how this stuff is we all are raised in the suppressive system, and it's in all of it's like, there's internalized racism, internalized sexism, there's internalized class nonsense, and like, just to like basically decolonize ourselves from all this thinking is a process. And part of it is to recognize all the different ways that it shows up in our society, like the education, the licensing exam, or like in my research, like Black girls are treated like they're older than white girls in education. Like they're not treated innocently as long. Like there's just a lot to learn. And it can be a liberatory process of freeing ourselves from a bunch of nonsense. And so I hope that inspires people individually too, because maybe individually is where we can focus, depending on the climate in the larger world, of which I'm not allowed to speak in this nonpartisan format.
Yes, thank you very much for that. Yeah.
Thank you so much to the Colorado Lead. This has been such a good discussion.
Absolutely. Absolutely. I think we should probably wrap it up since we're 15 minutes over. Does anyone have any last minute comments they would like to share? We will send the chat to everybody, and this will be recorded. And the recording will be available on the Colorado League's website under probably both the DEI task force page and the healthcare task force page. So if you want to listen to it again or share it with someone else, it will be there in the next couple of days.
And before you sign off, our speakers today have prepared a reference list of all the articles that they were referencing in their discussion, and I'll send that out to everybody. And I've also prepared an action list for where we can go from there, and that is mostly based on justice, equity, diversity, and inclusion. So thanks everybody for sticking with us.
No, thank you. It's been very helpful. It's nice to know there are many like-minded people out there.
Thank you.
Thanks.
All right. Go have some dinner. Take care.
Thank you guys so much.
Yeah.
You're welcome. Thank you.
Yeah, appreciate you guys.